Hello, welcome to my 45-minute presentation on orthopedic injuries. My name is Alexa Hughes. I'm a basic EMT. The objectives of this presentation are going to be to describe the anatomy and physiology of the musculoskeletal system, describe different types of musculoskeletal injuries, differentiate between open and closed fractures, recognize and manage orthopedic injuries, describe some general rules of splinting, and demonstrate how to apply different kinds of splints. The first thing we're going to focus on is the muscular system. So the main type of muscle that we're going to be focusing on in this presentation is skeletal muscle. This muscle is striated. You can see right over here. It is a voluntary muscle. It is manually controlled by the brain. It's, how you move your arms, your legs, all that good stuff. You have a say in how those muscles move. As opposed to smooth muscle, it's involuntary, and those muscles are parts of your organs. It's your GI tract, your blood vessels. Those muscles carry out automatic functions. You don't have to think about them moving. They just do their thing on their own. And then there's cardiac muscle, which is also an involuntary muscle. That muscle has specialized cells specific to cardiac function, has its own electrical system to keep the heart beating. And then we have tendons, which we'll also be focused on. That connects muscle to bone. Okay, so without tendons connecting the muscle to the bone, the muscle is pretty useless because it definitely needs the skeleton to keep its shape so that you can actually move around. The skeleton has about 206 bones. A major function of that is to protect your vital organs. Like I said, it allows movement by connecting to the muscle. The muscle moves the bone. It holds your posture, gives you that bipedal posture that we all know and love. And then in the bone marrow of your bones, in the skeleton, you actually produce blood cells. So that's where all of that production happens. And then we have our joints, which form when two bones come into contact. Joints are held together by a fibrous capsule and are supported and strengthened by ligaments. Ligaments connect bone to bone. So like tendons connect muscle to bone, ligaments connect bone to bone. Some joints allow movement, others do not. There are a few different types of joints. We have fibrous joints or fixed joints that are immobile. And those would be like your rib cage, your upper jaw, things like that. And then we have cartilaginous joints, which are partially mobile, like your pubic symphysis. Then we have synovial joints, which are flexible. And these are the more well-known joints like your knee joint, your elbow joint, your shoulder joint, your neck, all that good stuff. And those joints are what we're mostly going to be focused on when we're talking about orthopedic injuries and assessing patients and things like that. So there are many different mechanisms that can cause injury to a patient that would cause an orthopedic injury. There can be direct blows, indirect blows, twisting forces, high energy injuries. Depending on the amount of kinetic energy of the mechanism contains, it can cause injury at a distal point in the body, and that would be considered like an indirect blow. If you get hit at one point, but the injury is in a different area of the body, kind of, radiates that energy to a different point, causing a break in a different point than where the initial contact was. It's important to not become distracted by obvious deformities. However, a significant mechanism of injury is not always necessary to cause a musculoskeletal injury. There are some different risk factors that would increase somebody's risk of breaking a bone or tearing a muscle or anything like that. Some risk factors include weakening from tumors, infection, osteoporosis, any other generalized bone disorders. Specifically, geriatric patients are at a high risk for fractures and dislocations, even with low mechanisms. Grandma could just trip over her own shoe and break her femur. We're going to go over some different types of orthopedic injuries. We have the well-known fracture. A fracture is a broken bone. The simple classification for these is going to be open versus closed. An open fracture indicates that there's a presence of an external wound. So either the bone is protruding, there was a laceration from an external force that also caused a break. And then there's closed fracture where you suspect a broken bone, but the overlying skin is undamaged, so you don't have to worry about any open wounds when treating that. There are a lot of different types of fractures. What we're most concerned about in the field is going to be open versus closed fractures. However, I don't think it's a bad idea to go over the different types of fractures that they may diagnose in the hospital, because I don't think it's a bad idea to ever know this certain terminology. So we have comminuted fractures, which is a fracture in which the bone is broken into two or more than two fragments. It would be clean breaks. We have epiphyseal fractures, which is a fracture that occurs in a growth section of a child's bone, may result in growth abnormalities. Children have epiphyseal joints that begin to form into bone as they grow older. So when babies have like the soft spot on their head, it's because their bones haven't fully fused together to become one solid structure yet. So they have more vulnerability in those cases. Then we have green stick fractures, which are incomplete fractures that pass only partway through the shaft of a bone, but they can still cause substantial angulation, and they normally occur in children. Then we have an incomplete fracture that also does not run completely through a bone. It's a non-displaced partial crack, so there may not be substantial deformity or anything like that, but it would still be broken. Then we have an oblique fracture, which is a fracture in which the bone is broken at an angle across the bone diagonally. Then we have a pathologic fracture, which would be a fracture of a weakened or diseased bone, often produced with minimal force. This is what I was talking about, is common in geriatric patients, especially, if they have osteoporosis or they've had cancer in the past, maybe chemo has weakened their bones, anything of that sort. Then we have spiral fractures, which is a fracture caused by a twisting force, which actually causes an actual spiral shape break down the bone. And then we have transverse fracture, and that occurs straight across the bone, kind of like comminuted, but it didn't fully snap. It's not fully snapped. It's just a crack straight across the bone. Here's some different pictures of those. So that would be transverse, linear, that would be the oblique. You can have the oblique, I guess this would be oblique and comminuted. Spiral fracture, a green stick fracture, and a comminuted. So certain things to look for when you're suspicious of a fracture. Of course, deformity is going to be the biggest one. You want to see, is their limb shortened? Is it rotated? Is it angulated? It can be difficult to tell sometimes because some things are subtle. It's not always a huge significant deformity where their leg is completely bent backwards or anything like that. So you might want to just compare it with the other limb. That's always a good way to go, especially with like femur fractures, especially in older people. It can be difficult to tell whether or not it's actually broken. So you want to, like, if they're laying supine or if they, fell down, whatever, it can be easy to see if the leg is shortened or not. And even with arms, if they, broke their radius of their ulna, you can compare the limbs, and that is a good way to tell if there's a deformity or not. Any tenderness, point tenderness upon palpation. I mean, if you touch it and it hurts, it's a good chance that it could be a fracture. If the patient is guarding their limb, if they, broke their arm and they're holding their arm against their body and they don't want anybody to touch it, fracture is definitely something you want to be suspicious of. Any swelling. Sometimes if swelling is severe enough and it's, blown up like a balloon, it can very easily mask deformity. So sometimes you might not even be able to determine the deformity at all, and the swelling could be the only indication that you see. Bruising, of course, sometimes that can take some hours to develop. It doesn't always show up immediately. I think it starts to occur more so in the healing process when you break a bone. Then there's crepitus, which is like grating, grinding sensation. It can be felt and heard. If the patient does have any type of range of motion, you might be able to hear like a crunching sound, and that would be crepitus. Then you have false motion, which is body parts that are moving in ways they should not be. Like if your leg is moving where there isn't a joint, that would be false motion. Then we have exposed bone, obviously. That's pretty obvious one. Never push it back in. Don't ever attempt to push it back in. Solid rule. Then we have locked joint. Joint that once had motion but no longer does. So it's kind of the opposite of false motion. It's like when your elbow should bend, but it no longer bends, or it's extremely painful to bend it. Then we have dislocations. Dislocations are going to be a disruption of a joint in which the bone ends are no longer in contact. So you can see that in this x-ray over here. It's a dislocation of the elbow, I believe. Supporting ligaments, remember ligaments connect bone to bone, are often torn in these cases, especially severe dislocations. So if the ligaments tore, then it's pretty like sure thing that the dislocation isn't going to solve itself. Sometimes when people dislocate something, it just pops back into place. But if there was enough damage and enough energy in the mechanism to completely tear the ligament, then it's not going to just resolve itself. So some signs and symptoms of dislocations a lot of them are the same as a fracture. Marked deformities, swelling, pain, tenderness upon palpation, loss of motion, numbness or impaired circulation. It can be sometimes very difficult to differentiate between a dislocation and a fracture in the field. But the treatment for both would be the same: to immobilize the injury and try to minimize pain as much as we can. Sometimes it's a combination when you have a fracture dislocation. So that is where the joint is dislocated and a bone at either end of the joint is fractured. So if you dislocated your elbow but also broke your humerus, that would be a fractured dislocation. And like I said, pretty impossible to differentiate in the field, but just a good thing to know. Keep in mind that it might look like something, might be the other thing, might be both. Then we have sprains and strains, and a sprain occurs when a joint is twisted or stretched beyond its normal range of motion. It's like a partial dislocation, so it kind of pops out, but then it goes back into place. As a result, the supporting ligaments are either stretched and damaged, or they can be completely torn. It can definitely tear and not completely dislocate, but that would be considered a sprain. Joint alignment generally returns to a normal position and it's not significantly displaced, but it's still very painful. A strain is a pulled muscle, which results in stretching or tearing of the muscle and or the tendons connecting the muscle to the bone. So no ligament or joint damage, and there's often no deformity. However, and that can be even harder to diagnose in the field. But as you can see here, there are different grades of muscle strains. It can be a tiny tear, it can be a severe tear. These are more so like athletic injuries from wearing and tearing on the muscles, and maybe you just pulled it the wrong way and it just tore. Then we have amputations, which are considered orthopedic injuries. This injury is where an extremity is completely severed from the body. Treatment for an amputated limb in the field is always going to be to control the bleeding. In this case, we are going to be less worried about fractures and tears and all those things, and we're going to be more concerned with the hemorrhaging of the limb. Most likely, direct pressure, you're always going to try direct pressure first, but in this case, you're most likely going to control hemorrhaging with a tourniquet. And if one doesn't work, you can always apply another one. My picture just loaded. I don't know why it loaded late. Assessment. So, assessment of these injuries. Of course, we're always going to do a primary assessment first. Scene safe, PPE always. Those are going to be your number one priorities. Then you want to think about the mechanism of the injury. How significant is it? Was it high energy? Was it an indirect force? Was it a direct force? And then as an EMT basic, you always want to think about resources. Even as an ALS provider, you want to make sure, do I have enough resources to handle this patient and handle this scene? I say at the bottom, consider the need for ALS for pain management, even with low mechanisms. Especially like, say grandma fell down and she broke her femur and you want to minimize her pain and her stress before moving her, because it's good patient care. So if you have ALS available, I highly recommend giving pain management before moving and immobilizing patients. It just makes it better for everybody. You want to assess the patient's level of consciousness. Are they alert? Are they responding to verbal stimuli? Are they responding to painful stimuli? Are they unresponsive completely? And then your full primary assessment for any type of trauma patient is always going to be your XABCs. So a large concern with trauma patients is always going to be exsanguination, internal or external. This is a significant life threat and should be addressed first before airway and breathing, because if they bleed out, then there's no point in managing their airway. In many cases, orthopedic injuries will be isolated. It will be just that one injury, they just broke their leg or they just broke their arm, and it can be simple and non-life threatening. However, if it's a high energy mechanism of trauma, multiple body systems may be affected, and musculoskeletal injuries may be the lowest priority for this patient. You want to make your transport decision. Patients with simple mechanisms and isolated injuries may be further assessed on scene, and have their condition stabilize if there are no further complications. If it's not a multi-system trauma and you are, just having to immobilize that one limb and they're completely alert and oriented, their airway is patent, then you'll have a little bit more time on scene to stay and play. In those cases, when it's not, a full body trauma and you're not rushing them to the hospital, you can have a little bit more time to get some details of their medical history, like sample, the signs and symptoms, if they're allergic to anything, any medications they're on, specifically blood thinners. That's a big one. Because that can increase their risk of internal bleeding. So that's definitely an important question to ask if you get the chance. And then events leading up to what happened. And like I said, in what detail you explore this depends on the patient's condition, their stability, the priority of how fast you want to get them to the hospital. Do they have any type of condition that makes them more susceptible to musculoskeletal injuries? Does she have osteoporosis? Has she had cancer in the past? And then you have OPQRST. Does anything make it better or worse? Like, it can be limited in most cases for these types of injuries. However, if the mechanism is unclear and the patient is stable enough to gain details of the injury, like, you can gather details from bystanders, family members, nursing home staff, if the details of the injury are uncertain, because, that can happen. Then you want to move on to your secondary assessment. Here you're going to perform a head-to-toe exam. You want to start at their head, palpate their skull, look behind their ears for battle signs. Are they missing teeth? Do they have full mobility in their jaw? You want to palpate their spine, make sure there's no deformity. Do they have tenderness upon palpation? Check the stability of their hips, their thoracic cage. To check the stability of their legs and their arms, make sure that you're not missing anything. Make sure that, there isn't, they don't have a distracting injury that's making you miss something else. In these types of patients, especially, like I said, the high energy mechanisms where, it could be, it's a multi-system trauma. You want to maintain a high index of suspicion that there could be relating injuries. Identifying any extremity deformities that likely represent an injury. Anytime you find an injury, it should prompt you to assess neurovascular status. Any type of deformity, any tenderness, bruising, whatever, you want to check pulse, motor, sensory. So you want, if they injured their leg, you want to check their pedal pulse. Do they have a pedal pulse? Can they wiggle their toes? Motor, sensory. Can you feel me touching you? These things can indicate, if these things are absent, it can indicate impaired circulation, and that would automatically make that patient high priority, especially if they are missing a pulse. You are just going to assume impaired circulation, high priority. Blood is not flowing the way it should. We want to get this person to the hospital as soon as we can. And then when you're doing the head to toe, you also want to look for the presence of any lacerations, puncture, penetrating wounds, and that could alert you to the possibility of an open fracture. So if they have a deformity or if they just have pain and tenderness on top of an open wound, you want to definitely consider the possibility of an open fracture. Then once again, you're going to compare the swelling with the opposite limb, and that can help determine whether or not you have a fracture or a dislocation. And then during your secondary assessment, you also want to gather a baseline set of vitals. Shock can be very common in these types of patients. And then if there's any type of hyperperfusion at all, you'll go ahead and start to treat the patient for shock, which once again, that would make them a high priority patient. You want to get them to the hospital fast. When it's a non-significant trauma, low mechanism, isolated injury, you want to take the time to do a focused assessment of the isolated injury. You want to, remove the clothing, assess the entire zone of the injury, assess range of motion, things like that, to make sure that you're getting the full picture of what is actually going on in the injury, and maybe try and differentiate between a dislocation and a fracture. I mean, at the end of the day, we don't have an x-ray machine in the back of our ambulance. I tell patients that all the time. So we can't really for sure say what exactly is going on inside the body. So it's really just our best guess, but it's important to be able to do the best assessment that you possibly can. And then, of course, on the way to the hospital, you want to continue to reassess your patient always, repeat your primary assessment, make sure that their level of conscious is staying the same or hopefully improving if it was poor in the first place. Continue to assess XABCs. If there was any bleeding on scene, you want to make sure that that bleeding continues to stay controlled. Or make sure no more new bleeding has started. You want to continue to make sure that their airway's patent, that they're breathing normally, that they're circulating properly, that they haven't become cool, clammy, they're not diaphoretic, going into shock. Continue to assess those things constantly. And you want to continue to obtain more vitals and compare them to your baseline set of vitals. Make sure that your patient isn't declining. You want to reassess PMS, pulse motor sensory, especially if you have immobilized the injury. You want to make sure that you have not lost the pulse en route, because that is bad. You want to make sure that when you show up at the hospital that you tell the doctor, okay, the patient is immobilized, they still have a distal pulse, and you don't want the doctor to check and be like, oh, but they don't. Well, yeah. So you want to continue to assess those things. Make sure you're on top of it. Make sure you're monitoring your patients always. You're going to repeat that every 5 minutes for any unstable patient. So, those full system traumas, high energy mechanisms, you're going to repeat that every 5 minutes. You're going to make sure your patient is not declining. When they're not as high priority, it's okay to do it every 15 minutes to make sure that everything is still going well. Then we have treatment. Treatment for these injuries is always going to be step number 1, control the bleeding. You always want to make sure, especially with open fractures, amputations, multi-system traumas, you want to make sure that the bleeding is consistently controlled at all times. We're going to start off by doing direct pressure. It's always going to be step number 1, but you might have to escalate to a tourniquet or even possibly wound packing if you have, some type of penetrating injury like a gunshot wound, stabbing, or even if, anything like that, wound packing. You always want to try, you want to remove jewelry from the injury. If they have an injury to their wrist, you want to remove rings or bracelets, because those things can, they can impair circulation, and you want to try to maintain circulation consistently throughout. You're constantly checking for PMS, and you don't want to have anything that's gonna impair that. So preferably get the jewelry off as quickly as you can, because once swelling begins to set in, it can be a lot more difficult to remove that jewelry. And then if there's any open wounds, like for an open fracture, you're going to want to cover those open wounds with a dry, sterile dressing to try and prevent infection. You always want to keep those wounds clean and dry, and just make sure that they're wrapped up. Even if it's not openly bleeding, you want to cover those wounds, treat them properly. And then, of course, we're going to immobilize that injury. So we're going to apply the appropriate splint. We want to try and elevate the extremity above the heart to once again try and maintain circulation and make sure that everything is getting oxygen and the blood that it needs. In some cases, the most appropriate splint is going to be a backboard and a C-collar, because if it's a high mechanism and there are multiple body systems involved, you're going to just want to immobilize the whole body, because you're not going to want to be on scene wasting time and trying to splint every limb that's broken, when the best thing for the patient is going to be to spinally immobilize and get them to the hospital as fast as possible. If any swelling is present to any injuries, you can apply cold packs to the area to try and reduce that swelling. But there are many different types of splints that you can use for isolated injuries. We'll go over that in a second, but you also want to make sure that you're transporting to an appropriate facility. So if it's a, I went too far. If it's a high mechanism injury and it's multi-body systems, the orthopedic injury isn't necessarily the highest priority. You want to make sure you're transporting to a trauma facility, and that you're like, even if it's isolated orthopedic injury, like say an open fracture, you'd probably want to bring that to a trauma facility over like a freestanding emergency department. But yeah, so now we're going to go over how to splint different types of injuries. So we're going to demonstrate care for musculoskeletal injuries in this skills demonstration. We're going to demonstrate a rigid splint, traction splint, and a sling and swath. The materials I used were some padded boards, padded long boards, triangle bandages, a traction splint, and I used gauze wrap in my video, but for that material you can substitute ace bandage or co-band, whatever you have available. Some general rules of splinting that I want to keep in mind. Remove clothing wherever you're suspecting the fracture or dislocation. To inspect the area, you can remove clothing with the trauma shears, or depending on how loose the clothing is, maybe roll it up. You might not have to cut it, but if you have to cut it, it is what it is. You want to be inspecting the area for obvious deformities is obviously going to be the biggest one. But any open wounds, penetrating injuries, contusions, crepitus, things like that. So we always want to check PMS before and after splinting. We want to make sure they have a pulse, make sure they have motor sensation and sensory sensation. Can they feel you touching them? Can they wiggle their fingers? Before and after splinting. And then you want to continuously monitor during transport as well to make sure that the extremity has not become pulseless. If the patient has an initial pulseless extremity due to a fracture or a dislocation, you do have one chance to manipulate the injury and try to regain pulse back. However, if you were unsuccessful in your first attempt, you don't want to grossly manipulate the injury. You just kind of want to splint it in place and get them to the hospital as fast as you can. Before you splint anything, you want to cover any open wounds with dry, sterile dressings. You want to make sure that bleeding is controlled and that wounds are covered prior to splinting. That's going to be priority number one. If there's any resistance in positioning a deformed limb, you can splint the limb in the deformed position. You want to, like I said prior, not grossly manipulate the injury, causing possibly more damage and unnecessary pain to the patient. Splinting is a form of pain management, considering basic EMTs don't have the same, such a broad scope when it comes to pain management. So splinting is going to be one of the things that we can do to minimize pain for patients by keeping those injuries stable. Considering we can only really give Tylenol and NSAIDs, and we don't want to give NSAIDs in a case like this, because if the patient needs surgery, then NSAIDs are contraindicated. As always, scene safe, PPE before, walking into a scene in real life or any skills demonstration, simulation. You want to make sure that's always the first thing we're thinking about. Now we're going to move on to the demonstrations. Give my actors some grace. Neither of them are an EMS. But I think they did pretty okay for never doing this before. So we are doing the first skill we're going to do is rigid splints. We're going to be looking at how to do a padded board splint. Indications for this kind of splint could be a suspected long bone fracture. I'm doing it on someone's lower arm, so a suspected, forearm fracture, radius ulna, or a dislocation of the wrist, or a fracture of the wrist, because the wrist can be a tricky joint to wrap. But this splint that I demonstrate in the video would work perfectly for it. The specific video, I used 2 padded boards and 2 triangle bandages. First, we're going to go over long board splints. You want to make sure you stabilize the injury manually. Have your partner come over and hold a padded board underneath. You want to check PMS, make sure the patient has a pulse. Can you feel me touching you? Can you wiggle your fingers? Alright, I'm going to have you hold on to that. I'm going to bring it down just a little bit. And you're going to start at the distal end of the injury. You're going to go ahead and wrap around. You don't want to wrap over the joint. You want to make sure it's stabilized underneath the joints. You can also do this with an ace bandage, triangle bandages, co-band, whatever you have available. After you're done splinting the injury, you want to go ahead and check PMS again. Can you feel me touching you? Can you wiggle your fingers? Perfect. Alright. For the next part of our skills demonstration, we're going to be going over how to splint hinge joint injuries with rigid splints. Indications would be a suspected joint fracture or dislocation. Primarily, you're going to probably be using these splints on elbows and knee injuries. In the video, we're doing an elbow injury being splinted. We used 2 padded boards and 3 triangle bandages for this. PPE, you're going to assess PMS. Does my patient have a pulse? Can you feel me touching you? Can you wiggle your fingers? You're going to have your partner come over, manually stabilize the injury. You're going to tie a triangle bandage around the joint, obviously being mindful of the injury. You're going to tie it very loose. Then you're going to have your patient or your partner grab long boards, put the padded side, make sure it's touching both long bones, but it's not on top of the joint. You're going to do a figure 8 tie on each side of the long boards. We're going to tie them loosely at first. Do the same thing on the other side. Once you have both those tight, make sure they're up nice on the long boards. Try to make sure they're tight. Do a little bunny ear. And you're gonna untie this loose knot you put. You're gonna come up on top to find a little immobilization. Tie a nice tight knot. And you're always going to reassess PMS. Does my patient have a pulse? Can you feel me touching you? Wiggle your fingers. Perfect. For this next skill, we're going to be doing the sling and swath. Indications for this immobilization technique would be any injuries to the clavicle, scapula, shoulder, humerus, elbow, any radius or ulna fractures, dislocations. The patient will most likely be guarding this injury close to their body, probably having their elbow bent up and close to their body, and the sling and swath helps keep them in that position of comfort and take some pressure off of the injury by assisting them holding it up. It's a very simple technique with 2 triangle bandages. We'll take a look at that. PPE always. You want to check PMS. Make sure the patient has a pulse. Can you feel me touching you? Can you wiggle your fingers? All right. You're gonna have a knot tied in this part of the triangle bandage. Create a little pouch. Gonna cuff the injury. That. And then you're going to use this one as support. You go around their body. Make sure it's nice and secure. Check PMS again. Pulse. Can you feel me touching you? Can you wiggle your fingers? Perfect. For our final video, we are going to be doing the traction splint. Demonstrates the use of an inline traction splint. This immobilization technique is used to splint a closed femur fracture. Any obvious deformity, pain, or swelling to the mid-thigh without an open wound, we would assume closed femur fracture. Contraindications are any injuries of the knee, any suspected pelvic fractures, any amputations, avulsions where there's bone showing, tib-fib fractures, ankle fractures, things like that. Really, if it's an isolated closed femur fracture injury, we are going to be using this traction splint for it. I would like to add that holding manual traction is a very important part of this skill. The partner's job is extremely important. You want to make sure that you're holding a consistent amount of traction the entire time before the ankle hitch is secured and you have the splint holding traction. The person in this video unfortunately wasn't holding manual traction as well as I would have liked them to during the skills presentation. So please keep that in mind. Always do scene safe PPE before we do anything. You want to... Patient has an obvious deformity on his right leg, so we are going to measure against his good leg, his left leg. We want to make sure that the splint is about 6 inches past his foot. We're going to have our partner hold manual traction on the leg that is injured, preparing the patient for the traction splint. We're going to assess PMS, make sure the patient has a pulse. Can you feel me touching you? Can you wiggle your toes? Perfect. Now we're going to step over our patient, or he's going to walk around. Or pass equipment over your patient. So while your partner's holding manual traction, hold it a little better. Right there. Yep, just like that. And we're going to place it right under their butt, as comfortable as it could be. And then we're going to secure the ischial strap first. I'm going to make sure it's hugging the hip line. I'm going to grab the ankle strap. And then while your partner is still holding manual traction, you're going to attach the ankle strap. Make sure that's secure. Then you're going to attach the hitch and then pull traction. Preferably until the patient feels relief. Then then we're going to go ahead and do the rest of the straps. You're going to secure these not on a joint and not along the site of the injury either. And then you're going to reassess PMS. Patient still have a pulse. Can you feel me touching you? Can you wiggle your toes? Perfect. I wanted to thank you guys for coming to watch my skills presentation. If I had presented this to a classroom of students, I would have them pair off in groups of 2 to 3 after the skills presentation so that they could practice the skills on their own and receive instruction in person from other instructors in the class, whether that be me or maybe there's another teacher, whatnot. And once they felt comfortable enough, I would have them be evaluated by said instructors or myself, and they could receive a grade on the skill, but only once they felt comfortable enough. Thanks for listening once again. I've never done anything like this before, and I'm on night shift, and I'm currently still getting used to that, so I'm just a very tired person. Sorry if I sounded less than enthusiastic during any of the demonstrations or even my slides. I'm still enjoying exploring teaching, and I'm very excited to be gaining more skills in especially teaching something online. It's very interesting, but I appreciate the opportunity.